Okay, welcome back to this GI lecture. Let's talk about your role as a nurse whenever we managing patients with obesity. So obesity was officially recognized as a disease by the American Medical Association because of its effects on the body. So there are obesity and overweight. So primarily occurs in the visceral and subcutaneous tissues of the body. So you can go from this to that. And the classification is primary obesity and secondary obesity. And so primary obesity is accounts for the majority of obesity cases, and this is due to excess caloric intake for the body's metabolic demands. And then secondary obesity results from various congenital anomalies, chromosomal anomalies, metabolic problems, or CNS lesions and disorders. This is your body mass index calculator. Basically tells you the degree which a patient is classified as underweight, healthy, or normal weight, overweight, or obese. So weight to hip ratio is the method of describing distribution of subcutaneous and visceral adipose tissue. So you measure the waist and you divide by the hip measurement and you get your ratio. Ideally, less than 0.80 is the good weight. So anything more than 0.80 indicates a high risk for health problems. People with more visceral fat are at an increased risk for cardiovascular disease and metabolic syndrome. It is the preferred tool when patient is predominantly muscular. So I think I've mentioned to you guys that I am in the Navy Reserves, and we get these guys that work out a lot. And so their weight based on height and weight is basically showing them as being overweight for the Navy standards. And so the way they get around to make sure that the people who are muscular are not at a disadvantage is by using the waist to hip ratio. So there are two types of obesity, so to speak. The body shape classification, there is the gynoid. Gluteal adipose tissue accumulation leads to varicose veins, osteoporosis, cellulite, and then there's trapped fat stored as triglycerides. And then we have the android obesity, which is abdominal adipose tissue accumulation, and puts risk for heart disease, metabolic syndrome, and cancer. So metabolic syndrome, if patient has 3 of these things listed here, then they're considered to have metabolic syndrome. So android obesity, excess fat in the stomach area is a greater risk factor for heart disease than excess fat in other parts of the body, such as on the hips. If they have a high triglyceride level greater than 100, a low HDL cholesterol level less than 40, and just as a side note, I've been told that red wine and oatmeal helps boost your good cholesterol. Don't take my word for it. That's just me, because I like wine and I like oatmeal. And then if patient has high blood pressure or high fasting blood sugar. So if they have any three of these things, then they're considered to have a metabolic syndrome. In the United States, obesity affects 1/3 of the population. 66% of those over 20 years old are either overweight or obese, and it's a second leading cause of preventable death, and third leading reason for liver transplantation because of fatty liver, like we talked about in my previous lecture. I would say if this was in Kenya, there'll be in Kenya, basically, the more weight you have, you're considered to have more money. So basically, when Kenyans look at Americans that are overweight, the assumption is that these people have a lot of money. And that's not always the case, because we all know that's not true, because there's some social economic component to people being overweight and having more health issues than people with access to resources and better health or better health care. There's also strong evidence of genetic predisposition, and then the FTO gene has a strong link to BMI. So this is how the FTO gene expresses itself. So input to the hypothalamus is received from the periphery from many different hormones and peptides. And as you can see, the cholecystokinin is duodenum jejunum to the hypothalamus. That all these linkages. And so if there's something wrong with the hypothalamus, then there might be a problem with weight. Here are the portion sizes. Yeah, supersized stuff. Okay, take a moment to review these slides and see all the obesity risks related to different body systems. Refer to your nutritional support service. Engage in an exercise program daily. Behavior modification, support groups. So for behavior modification, this ranges from basically what you eat, whether you are sedentary for the most part in your workday. Let's say you work in an office and you always sit for the most part of the day. So if people start making a few changes here and there, it could help with the behavior modification. And then we have the bariatric surgery, which is used to treat obesity. It's currently the only treatment found to have a successful and lasting impact on sustained weight loss for severely obese individuals. But for them to qualify for the surgery, they have to meet the criteria listed here. So basically, you have to have a BMI equal to or greater than 40, with one or more obesity-related complications. I have a problem with that. So what they're basically telling you that for you to have surgery, even though you have a BMI greater than 40, you have to have a complication before they can do surgery. How about we do the surgery to prevent the complication? I don't understand it. This is probably dictated by insurance companies. And then the patient has to have the presence of mind to understand the risks and the benefits. Oh my Lord, I have a problem with this one too. They have to have been obese for more than 5 years, seriously? And then they have tried and failed to lose weight. Wow. They make it really hard for people to get this surgery. And then the patient cannot have any serious endocrine or liver problems. They have to have psychiatric and social stability. And then, of course, the healthcare team has to be available to do it. Surgery will decrease or eradicate high-risk conditions. So here are some of the bariatric surgical procedures. So there's this one where they create a pouch, and then this is the banding, and then there's the vertical sleeve gastrectomy, and then there's this one, biliopancreatic diversion with duodenal switch. It looks complicated. And then there is the I don't know how to say it, gastric bypass. So they create a pouch with a 20 to 30 ml capacity. Oh, there's a description. So the E1, the Roux-en-Y gastric bypass procedure involves constructing a gastric pouch whose outlet is a Y-shaped limb of a small intestine, like that. Okay, so for this procedure, and pay attention here, my good people, since there's so many incisions everywhere, trying to connect everything, like here, around there, and then here. So the priority nursing diagnosis for this patient will probably be, scratch that. Don't even think about what I just said. So for this procedure, for purposes of your testing, you have to know how to explain it to the patient. Basically, if the patient asks you what this is, what can you tell them? How would you describe the procedure? Okay, moving on. Restrictive surgeries basically reduce the size of the stomach to 50 ml or less. Causes patient to feel full more quickly, and so that reduces the amount of intake, and therefore that reduces the amount that gets absorbed. So normal stomach digestion and intestinal absorption of food, decreased risk of anemia and cobalamin deficiency. So these patients have to have supplements. Adjustable gastric banding, AGB. The stomach size is limited by inflated band, and the band is connected to subcutaneous ports, can be inflated or deflated to change the stomach size. And then, so whenever you see a blue highlighted and you're able to click on it, you can watch. It's basically a link to a video, so you can click and watch the video. We're not going to do that in this presentation, but you can do it on your own. So 85% of the stomach is removed for this varicose sleeve gastrectomy. It is not reversible. Stomach function is preserved. Most common procedure, and it has less complications. Okay, and here it is. And like I said, whenever you have the blue highlighted writing, just click on it and watch the video. It has low complication rates, excellent patient tolerance, stomach size is reduced with a gastric pouch, anastomosis that empties directly into the jejunum. Remember how I said you should know how to describe this, and so you should, because you'll see it somewhere very soon. Here are some of the variations of the Roux-en-Y surgery. Stapling stomach without transection to create a small 20 to 30 ml gastric pouch, creating an upper and lower gastric pouch and totally disconnecting the pouches, and then creating an upper gastric pouch and completely removing the lower pouch. Preoperative care. So patients who are obese are likely to suffer other comorbidities such as diabetes, altered cardiorespiratory function, abnormal metabolic function, and atherosclerosis. So basically, remember how the criteria to meet bariatric surgery is to be BMI greater than 40 and then have something else going on. There we have it. So if you have diabetes and your BMI is greater than 40, then yeah, you're a candidate for bariatric surgery. But then you have to have social stability and psychiatric stability, and so they have these patients consult a social worker. They're basically a team approach. So if they have cardiac issues, they're going to need a cardiologist on the team, and if they have pulmonary issues, they're going to need a pulmonologist as part of the team, and then gynecologist and gastroenterologist or other specialists. I'll add their social work for referral services and support, community support. So wound infection is one of the most common complications because of the many layers of flabby skin folds, especially in the abdominal areas. So we need to teach these patients about skin care. And so prior to surgery, they have to have a skin prep, and then patient need to bathe or shower frequently for a few days before admission to the hospital, basically to get rid of all that skin flora that might lead to infection after surgery. And obesity can make breathing shallow and rapid, and so instruct patient in proper coughing techniques, deep diaphragmatic breathing, and methods of turning and positioning to prevent pulmonary complications. So this is all the teaching that should occur before patient undergoes surgery, and then after surgery, we'll have to keep encouraging them to use maybe incentive spirometer to help with the breathing, and then make sure they are able to reposition themselves in the bed. And if not, then we can provide assistance. For those of you who've been at UC Davis, and again, I keep referring to UC Davis because that's all I know as a nurse. We have lift team that rounds every 2 hours, and you can always request their help in between. And then also it could be helpful to have like a trapeze, overhead trapeze for the patients to independently position themselves post-op. Post-operative care, larger blood pressure cuff, large gown. We call them angel gowns. They are different color and they provide really good coverage for our bariatric patients, and make a bariatric wheelchair available, or a wheelchair with removable arms so a patient is able to slide in and out. Oh, there it is. Strongly reinforced trapeze bar over bed for movement and positioning. Trained staff should assist transfer of unconscious patient. This is when you need your lift team because you only get one back through your lifetime, and so if you break it, you'll be cutting your career super short. During transfer, ensure that patient's airway is stabilized and the pain is managed. In severely obese patients, it's essential to monitor for rapid oxygen desaturation. So we'll have these patients on pulse oximetry to monitor them. And then we want to make sure they start ambulating early, so we can put in a PT, OT request, and they should be seen as soon as it's possible. And then frequently increase ambulation after initial move. We can use SCDs and heparin post-op, and patients are discharged in 1 to 2 days. So for those of you who did your second semester rotation at UC Davis, you may have been on Davis 12, which is our designated GI unit. So pain is a major consideration for these patients, and so we should be medicating them as frequently as necessary, especially during the immediate post-operative period, because if they're in pain, they're not going to want to move, and we need these patients to move as soon as possible, and so we have to make sure their pain is well controlled. And then provide education. I cannot emphasize enough on that because this is a major lifestyle change for these patients. And so if they cannot maintain the prescribed diet, they may end up with complications. And so it is imperative that they understand that prior to the surgery and after the surgery. So the diet is generally high protein, low carb, and low fats, low roughage, 6 small feedings, fluids not to be ingested with meals. Remember the dumping syndrome. Cobalamin injections or intranasal spray will prevent cobalamin deficiency anemia. Okay, so complications from bariatric surgery is the anemia, remember the cobalamin, and then vitamin deficiencies because of the absorption rate, and then possible diarrhea, and then psychiatric problems. So the psychiatric problems could be related to their body image because once they get this surgery and they lose all this weight, they'll have a lot of skin folds and skin flapping everywhere, and so this could really mess up their way of thinking and be very self-conscious of their body image. Possible peptic ulcer formation, and then dumping syndrome. Remember we talked about this in my previous lecture. And then small bowel obstruction, gallstones, and then GERD. But the expected outcomes, if everything goes as planned, we're hoping for long-term weight loss, improvement in obesity-related comorbidities, integration of healthy practices into the lifestyle, support, improved self-image, and then they have to monitor for possible adverse effects. Gerontologic considerations, basically our older population, number of older obese persons has risen, more common in women than men. Decreased energy expenditure and loss of muscle mass are important contributors. Exacerbates age-related problems, like an example is arthritis. And this is the end of our slideshow for this. So you'll need to know for gastric bypass discharge teaching diet, what diet do these patients should be on, and what foods to avoid with dumping syndrome. I think that's about it for our GI lecture.